The Knowledgeable Provider podcast is intended primarily to entertain, also to inform, but it is not a substitute for actual medical training and should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, please make an appointment to see your own knowledgeable medical provider. The opinions expressed by me and anyone else who happens to appear on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than the lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. Look, this is all for fun, okay? Don't sue me. All right, on with the show. Hello, welcome to Knowledgeable Provider. I'm your host, Jody Marks. Today I want to continue the Nutshell series that I started a couple weeks ago with hypertension. I'm going to continue now and talk about cholesterol or lipid management. And this is a thing that I think we tend to make really a lot more complicated than it has to be. If you look at all the literature and guidelines and whatnot, it's pretty easy to get confused about what you're really supposed to do. Even as a healthcare person, I can only imagine what patients must feel like when they start trying to research cholesterol and try to figure out whether or not they should take medicine for it or whatever. So what is cholesterol in the first place? It's a fatty, kind of waxy substance that we need to make many components of our bodies. The main things are cell membranes and hormones. We tend to think of cholesterol as a bad thing, but really it is a component of many things in our body. So it is something that we need. We just don't need it in excess. We separate the cholesterol into HDL and LDL, so high density and low density lipoprotein. And more commonly, we think of these as good and bad cholesterol. So the HDL doesn't seem to have much to do with causing buildup in the walls of the arteries. And in fact, the HDL has some role in transporting the other cholesterol, the LDL, back out of the bloodstream and into the liver. So we think of that as the not harmful cholesterol. The LDL, on the other hand, is the one that's involved in forming plaques or blockages in the walls of arteries. And so that's what makes us prone to having heart attacks and strokes or ischemic issues in limbs. You know, anytime you have an artery that's blocked, we name that condition based on what's downstream of that, right? So if that happens in the coronary artery, it's a heart attack. If it happens in a cerebral artery, it's a stroke. If it happens out in the periphery somewhere, it's peripheral artery disease. But it's all the same idea. Plaque builds up in the walls of the arteries, the lumens of the vessels get narrower, and eventually either it completely plugs off or the plaque ruptures, and then the blood clot that forms to try to fix that is what plugs off the arteries. So the goal of managing cholesterol is to lower the amount of LDL. So that's really the quick version of what we focus on in lipid management. When we look at that lipid profile, we want to see less LDL and more HDL. And it's interesting to see what people's natural makeup of cholesterol is. You know, some people just have very high HDL naturally. And we think that having a favorable ratio of HDL to LDL is probably protective. Those people are probably less likely to have adverse cardiovascular events as time goes on. But what we really focus on as far as treatment is getting that LDL down, lowering that LDL. And I'm just going to keep this really simple. Later, I'll actually go through the guidelines because you can get pretty complicated with this. There's all kinds of different ways to estimate risk and different ways to figure out the goal and different ways to figure out what statin and how much of a statin, blah, 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 blah. It gets really complicated. And I will try to go through some of that for you. But right now, I want to just really boil it down and focus on the quick and dirty of clinical practice for doing this. So we bring somebody in, we check their cholesterol. We still require people to fast, but there is some thought that you really don't have to make people fast to accurately estimate their cardiovascular risk. But we still ask people to do that. So we have people come in fasting, we check their lipid profile, we get a total cholesterol, the HDL, the LDL, and then triglycerides. Triglycerides are lumped in with cholesterol, but really triglycerides are more of a direct measure of how much stored fat you have from whatever you are eating. So the fat that we take in our diet that's not immediately used is stored as triglycerides. Triglycerides are not part of the actual plaques that form, but there is some thought that they contribute to inflammation or atherosclerosis over time. I think the exact relationship there is not really known, but we feel like less triglycerides is better than more triglycerides in general. So we get the lipid profile and we pretty much look at the LDL. if it's really high, we need to do something to bring it down. How high is really high? The consensus is that an LDL greater than 190 is like too high, period. We need to think about checking people for familial hypercholesterolemia in those situations. And regardless of whether they have that or not, we really need to bring that down. Most people, of course, are going to be somewhere in between. For people who have never had a heart attack or a stroke, your ideal LDL is under 100. If you've had a heart attack or a stroke, then you want to push that even lower. The ideal goal would be to get it below 70. So for most people who fall in the range of somewhere between 100 to 130, 140, I'd say that's most people. We just individualize that decision, assuming they've never had a heart attack or a stroke. Then you start looking at their other risk factors. Are they diabetic? Do they have high blood pressure? Do they smoke? And this is where the cardiovascular risk disease calculators come in. Basically, you can input all of this data about a patient and it will spit out a number and tell you what their risk of having a heart attack or a stroke over the next 10 years is. So you kind of look at all that and you just decide who do we need to push this with and who can we let it ride with. So a patient at low risk who has LDL in the kind of low 100 range, probably going to let that ride. High risk patient, we want to do something to lower that LDL. And pretty much what we do is put people on statins. Obviously, there is some role for lifestyle modification, and it's the same things that we talked about before with hypertension, right? More frequent exercise, more fruits and vegetables, more lean meats, less of everything else. Mediterranean diet, DASH diet, always safe to recommend. And then control the other risk factors. You need to quit smoking, you need to control the blood sugar, you need to control the blood pressure. And if somebody can do all those things and lower their cardiovascular risk and keep their cholesterol down without taking medication, hey, I'm all for it. My experience has been that most people can't do that. There's a big genetic component to cholesterol. We're each just prone to either having a lot of cholesterol or not having a lot of cholesterol. And you can affect that a little bit with lifestyle modification. Really, from what I've seen, the people who have high cholesterol just kind of have high cholesterol no matter what they do. And then you see the opposite. You see the patients who you would look at and swear that they are about to drop dead and their numbers end up being perfect. So again, like I said in the hypertension episode, you really can't tell from the outside. You can't tell by looking what someone's cholesterol is going to look like. So if we do decide to use medicine, that's when we're reaching for the statins. These are medicines that stop the body from actually producing cholesterol in the first place. They work on the liver. I'm hearing more and more pushback from patients on taking statins. It's not unusual for someone to go, oh no, I'm not taking a statin. Oh, the statins are bad for you. And I'm not really sure where that's coming from. In preparing for this episode, I actually just Googled, why do people not like statins? And the whole first page of results was stuff from legitimate medical places saying, don't be afraid of statins. Statins are good. Statins are fine. There was one thing that came up, something about cardiologists against statins, where some dude with a PhD decided that he was going to do his own research and he thinks the data are not reliable about statins and they're actually killing everybody. And it seems very conspiracy theory-esque. My general MO is to go along with what all of the legitimate medical societies and authorities are saying. And overwhelmingly, it seems like the evidence about statins is good and statins work and statins help people not have heart attacks and strokes. So as long as that's the case, I'm going to go along with what legitimate medical advice seems to be. Obviously, if that ever changes, I'll change as well. Everything's always changing in medicine. We always have to be open. But I think we've seen during the pandemic that we medical providers are just as susceptible to misinformation and being swayed by questionable sources as anybody else. I've seen more than a few patients who got treated for COVID with ivermectin by other providers, even though the actual medical authorities are very, very clear that that is not an effective treatment for COVID. It's not appropriate to do that for COVID. Just last week, a lady was kind of yelling at me because I wouldn't write ivermectin for a COVID. She said, why won't you do this? I said, it's not a treatment for COVID. It's just not. She said, well, yes, it is. And then that makes me feel like I'm crazy and have to go back and research and question myself. But I think a big part of our job as medical providers is not always to try to make people happy when they're asking for things that we know are not right. Have I ever written somebody an antibiotic that they probably didn't need just because they wanted it to make them happy? Yes. Have I ordered lab tests that probably aren't indicated because somebody asked for it to make them happy? Yes. I'm just as guilty as anybody else of doing stuff like that. But somewhere you have to draw a line in the sand and say no when people ask you for things that are really just out there and unequivocally inappropriate. So anyway, that's where I am with statins. They're still the best thing we have for lowering people's cholesterol, and we're pretty sure that that keeps people from having heart attacks and strokes. So as long as that's the case, I'll keep using them. You can look up all this complicated stuff about if their risk is between A and B, then you use a moderate intensity or a high intensity or a low intensity, and percentages of LDL lowering that you can expect from different statins of different intensities. And man, it gets confusing. Here's my strategy. If I'm going to put somebody on a statin, I put them on rosuvastatin, brand name Crestor. If you need to lower their cholesterol a little bit, you give them a little bit of rosuvastatin. If you need to lower their cholesterol a lot, you give them a lot of rosuvastatin. It works. It tends to be well tolerated among the statins. It's generic, so that's my go-to. If someone's not going to be able to tolerate a statin, the main reason is probably muscle pain. And there's a lot of debate out there about whether this is even a real thing. We see these studies that are like, oh, look, we tricked all these people into thinking they were taking statins and they still had muscle pain. Or there's like a thought in the medical community that this is really not even real, that it's, I don't know, mass psychosis or something. But in my experience, people really do have muscle pain that really does get better when you take away their statin sometimes. So I tend to just trust the patients and go by what they tell me. Most people tolerate statins just fine, but if they come in complaining of muscle pain, one of the first things I always do is tell them to just hold their statin for a couple of weeks and see if it makes any difference. A lot of times it doesn't make any difference, but every once in a while someone will go, oh, that fixed it. Muscle pain's gone. So, okay, we'll go with it. If that happens with a particular statin, sometimes you can find another statin that won't do the same thing. Rosuvastatin tends to be pretty good about that. If we have to go to something else, usually I'll go to the pitavastatin, brand name Livalo, to a newer one. Once we start somebody on a statin, we bring them back in a month to recheck their liver function to make sure the statin's not harming their liver and to reassess the cholesterol and see how well we're doing. People's cholesterol will come down if they take a statin. If somebody's supposed to be on a high dose of a high intensity statin and you get their labs back and their cholesterol is really high, that means they're not taking their statin. They just work. And we have found in our practice that you don't have to take it every day in order to get some benefit from it. We have people that take it every second day or every third day, and that's enough to keep their cholesterol down where we want it. So we're good with that. Whatever arrangement we can come to with the patient to help them out and have them be comfortable with what they're doing is fine with me. If we can't use a statin for whatever reason, or the patient doesn't want to use a statin, we have some other options for helping to lower LDL. The main one is called ezetimibe, brand name Zetia. It works by stopping cholesterol absorption in the small intestine. You also have bile acid sequestrants that work by a little bit different mechanism, but it's the same idea. You prevent the cholesterol from ever being absorbed from the diet in the first place. And then you also have bempedoic acid, brand name Nexletol. It also works by stopping the production of cholesterol by inhibiting a specific enzyme. And then you have this newer class of medicine called the PCSK9 inhibitors. These are monoclonal antibody medications that work to enhance LDL clearance from the body. The two that are available currently are evolocumab, brand name Repatha, and alirocumab, brand name Praluent. These are both given as injections, so that's something that we would send people to cardiology for. These are also both new, expensive medications, so as of now, these are sort of a last resort if we can't get their lipids controlled any other kind of way. There are other types of medicine you can use specifically for high triglycerides. These are the fibrates. Generic names are fenofibrate, fenofibric acid, or gemfibrozil. They work by stopping the production of triglycerides in the first place. There's a newer medication out called icosapent ethyl, brand name Vascepa. My understanding is that that is just very concentrated form of fish oil. There's some debate as to whether or not fish oil supplements are helpful for reducing cardiovascular risk. I generally don't have a problem with my patients taking them if they want to. This medication is like super duper concentrated. They take an ingredient of the fish oil called EPA, which stands for eicosapentaenoic acid. That's an omega-3 fatty acid. I guess that's probably the more common name that you would hear. And it's just a super concentrated version of that. So the rep for Vascepa tells us it's like taking like 10 bottles of fish oil or something to get this amount of EPA. It has the indication for hypertriglyceridemia specifically, as well as just cardiovascular risk reduction. Again, new brand name medicine, so probably going to have more trouble getting it covered, getting it paid for. So that's pretty much it. That's the quick and dirty version of lipid management. I'll go back and talk now a little bit more about the more technical guideline kind of information. And I'm looking at the 2018 AHA-ACC guideline here. They recommend assessing a person's cardiovascular risk somewhere between 20 and 39 years of age. We definitely start checking cholesterol routinely at age 40. In our younger patients, we kind of just offer it if they want to. If we get a 23-year-old that just wants to have labs drawn once and see where they are and make sure there's no concern, or if there's a strong family history of people with high cholesterol or people having heart attacks and strokes, we might recommend that a little more stridently. So in that younger age group, obviously you probably want to focus more on lifestyle modification. I would not be in a hurry to put a younger person like that on a statin unless there was some pressing reason to. Their LDL is through the roof, or if they have known cardiovascular disease for some weird reason. If they're diabetic, if they're smokers, obviously that would bump somebody up the list. But in general, we're not in too much of a hurry to bring the cholesterol down in that younger patient population. From 40 up to 75, it's an individualized risk kind of situation. So here's where you get into all the little guidelines and risk calculators and that sort of thing. If somebody has known atherosclerotic disease, you want to put them on a statin. You want to drop their LDL by 50% from the baseline. If they're a very high risk patient, you want to try to drop that LDL below 70. And all the units I'm using, by the way, are milligrams per deciliter. If a person has severe primary hypercholesterolemia, LDL greater than 190, you don't have to mess with calculating a risk score. You need to put those people on a statin and bring that LDL down as much as you can. In the 40 to 75 age group, patients with diabetes should be started on a statin if their LDL is greater than 70. In that age group of 40 to 75, people who do not have diabetes, if their LDL is greater than 70 and their 10-year risk calculation is greater than 7.5%, the recommendation is to start a statin, with the goal being to reduce the LDL level by at least 30%, or if that 10-year risk is above 20%, then you want to reduce the LDL level by at least 50%. In that age group, if the decision about statin therapy is uncertain, the AHA says you can consider getting a CAC score, so coronary artery calcification score. You order a coronary CT scan for that, and if that turns out to be 0, then pretty sure that means that they don't have much risk of having a heart attack, so we can not do the statin. Those risk calculator tools are only for people who've never had a heart attack or a stroke. Once you have a heart attack or a stroke, then you're just considered high risk. And so in those patients, we want to do absolutely everything we can to lower their risk of having another heart attack or a stroke, so we don't have to pay attention to the risk calculators anymore. For older patients above 75, we tend to just kind of proceed as we do with everybody else. Check the cholesterol regularly, manage it. There is some thought that you can actually stop screening after age 75 and just not worry about it. It kind of makes sense that something that's going to take years to cause a problem, hyperlipidemia, you don't have to worry so much about during the last few years of somebody's life. Although, obviously, that's very patient dependent, right? A 75-year-old could possibly have another 30 years to live if they're in really good shape and have good genes and are generally doing well and healthy. So you have to make that decision based on the patient in front of you. I think it's also important to remember that statins not only lower the LDL, but they also help stabilize the plaques in the walls of the artery. So it's not just that we're getting the numbers down, it's also that we're physically stabilizing the plaques so that they're not as likely to rupture. And so in my mind, that's a pretty good reason to keep folks on statins even in their later years if there's any concern about them having increased cardiovascular risk. Sometimes the question comes up, can you lower the cholesterol too much? Is there any adverse effect of having too low cholesterol? And the answer, in theory, is yes. We do need cholesterol for some things, like I mentioned earlier. So you can't have zero cholesterol. But so far, we really haven't found the lower limit of how much you should lower somebody's cholesterol. Pretty much lower is better when you're talking about cardiovascular risk. There's not any agreed upon cutoff of like, oh, this is too low, we have to back off now. So it's not something we really worry too much about. I do want to mention that, like a lot of things in medicine, there's not complete consensus on all this. The American Family Physician podcast this past week was about the new Canadian guidelines for lipid management in primary care. And they're much less aggressive, I would say, than the AHA-ACC guidelines. They recommend only screening lipids in people without cardiovascular disease who are not taking any kind of lipid-lowering therapy, only about every 5 to 10 years. They recommend starting risk assessment in general at age 40, not age 20. They do not recommend fasting prior to testing. They recommend against looking at the CAC score. They're on the same page about statins in general, as well as ezetimibe and the PCSK9 inhibitors. They recommend not testing people over 75 for lipids. They don't generally recommend starting a statin after age 75, but they also don't recommend stopping a statin if they're already on it just because they reach age 75. I guess there's been some concern about statins causing cognitive deficits. They recommend against messing with a statin for any kind of cognitive concerns. They recommend against worrying so much about target lipid levels and against continuing to test lipids after somebody is on lipid lowering therapy. They also recommend against any sort of baseline testing for CPK or AST, ALT levels before starting statins in a healthy patient. So a little bit different strategy there. I should mention too that there are these other tests floating around out there that people talk about or occasionally somebody will order for some reason. These are lipoprotein A, or people call that LP little a, and then apolipoprotein B. Those are some kind of different ways at looking at lipids that's not just about the quantity or the amount. It's also more about the characteristic of the molecules and how likely they might be to cause a problem. Currently, there's not really a role for that as far as guidelines or risk assessment or anything. I've seen a couple of specialists check those in a couple of different patients. I don't really know why, but that's definitely not a standard thing. And right now, it's not something that we are ordering routinely for sure. The Curbsiders did an episode about that a while back, and their recommendation is maybe you can use that stuff if you're very concerned about a particular patient's risk and you want to really, really make sure that you're doing everything you can to lower their cardiovascular risk. So that's pretty much it. That's cholesterol. I'll put links to all these guidelines and some helpful articles that I reviewed when I was preparing for this. If you have any questions or thoughts, if I said anything that's wrong, if there's anything you'd like to add, feel free to reach out. I hope you're enjoying the little nutshell series I'm doing here. Thanks for listening. Have a great week. See you next time. All right, that does it for this episode of Knowledgeable Provider. I'm your host, Jody Marks. Thank you so much for listening. Please be sure to like, subscribe, or follow on your preferred listening platform. Give us a nice 5-star rating and leave a nice review. If you'd like to help support the show, you can do that at patreon.com/knowledgeableprovider. And as always, stay safe, take care of yourself, and take care of your patients in that order.